the contrary not content, the content's habit. Question for short debate: sexual and reproductive health care in England. Baroness Barker.
My Lords, I thank all noble Lords and particularly the Minister who will be contributing to this debate. Their participation at this late stage is very much appreciated. And I'd like to thank the British Association of Sexual Health and HIV and the British HIV Association, Terence Higgins Trust and the National AIDS Trust for their briefings for this debate. And I also want to draw the House's attention to my role as co-chair of the All-Parliamentary Group on HIV/AIDS and the All-Parliamentary Group on Sex and Reproductive Health. My ongoing involvement in those APPGs reflects my very strong held belief that I've had since I was a young woman that giving people, particularly young people, scientifically correct, fully inclusive sex and relationship education information not only protects them and enables them to study, work and live their lives to their full potential, but it also benefits the whole of society in terms of both health and economics. The thing is, the reason why I want to have this debate, my Lords, is that sexual and reproductive health care in the UK is in a crisis. And that's not me saying that, that's the local government association, the British HIV Association and the British Association of Sexual Health and HIV, i.e. those people on the front line trying to hold these services together and make them work. Data from the UK Health Security Agency shows that demand for SRH services have been increasing year on year, and they hit a record high in 2023, no signs of abating this year. And that increase in demand has not been mirrored in an increase in resource and staffing, as such that the recent Local Government Association report showed that services throughout the UK are at breaking point, with people being turned away from services which are often open for very minimal times when people can't get to them, due to a lack of capacity. And due to the deterioration in numbers of people training to be GUM, genital urinary medicine physicians in the UK, there is a real possibility that there will be very soon a future without adequately trained experts in outpatient management of complex and complicated STIs. And that, my Lords, is worrying for us all. There are huge issues about recruitment and training and staff that can be traced back to changes that were made under the commission changes under the Health and Care Act of 2012. Those reforms which put public health back into local government were right in principle. Public health and prevention and surveillance of disease should start not in the NHS but in communities where people live. The problem was that reform coincided with a plummeting of local government finance, and consequently the commissioning of services had been so severely depleted that the services have deteriorated to the point where we have reached the highest levels of cases of gonorrhea since the 1920s and the highest rates of syphilis since 1948. And the high rate of those diseases and the lack of capacity of people being seen in SRH services has resulted in people presenting late and with levels of infection and being so late that they may have harm which is irreversible, which could have been treated properly had they been seen earlier. There's also been a resurgence in neonatal syphilis in the UK. Something that we thought was history is now back. We've got significant neonatal morbidity. And in addition, reduced NHS service capacity has reduced the access to preventative SRH services, including vaccinations and HIV provision of PrEP, both of which are critical to reducing future transmissions of STIs. In some areas of the UK, particularly outside London, there's been a disproportionate effect as small clinics have been hit more than others. So it's really quite important to understand in this debate that there are two types of specialists who deliver the majority of SRH and outpatient HIV care in the UK. gum clinics and HIV physicians who are trained in medicine and specialise in STI and HIV diagnosis and management. And then secondly, there are community and sexual reproductive health specialists who train predominantly in women's healthcare and who specialise in gynecological and reproductive care of women across their life course. Most provision of specialist contraception and training of other healthcare workers in contraception and the leadership of systems across secondary and primary care is done by community SRH consultants. Now, Dame Leslie Reagan has done tremendous work in the development of the women's hubs. And I want to ask the Minister whether the government plans to build on that work to make those into one-stop shops for women where they can have their reproductive and sexual health issues dealt with all at once. HIV treatment is different. HIV services are open access and anybody can come into them. But, my lords, there is a huge problem in the HIV workforce. Not only is there a huge demand, there are so few specialists, consultant specialists around to help other staff to train and to develop, that we are now having a real problem in recruiting trainees into genital urinary medicine. That means, my lords, that those services are becoming ever so much more fractured and dependent, and there is a knock-on effect back to general practice and to pharmacies who simply do not have the specialist knowledge and training to deal with those more complex cases. Nurses and allied healthcare professionals are doing much more than they did a year ago, but they really can't deal with the sorts of complex cases that are now being presented to them. We've got an inadequate number of consultant specialists working in the field, and that is having an adverse effect on training. My lords, the commissioning arrangements really are at the root of the problem in all of this. No one is taking responsibility for ensuring that the next generation of doctors and nurses in sexual health services are being trained. No local authority has a training plan, and there's no cohesion nationally to drive accountability when it fails. Services that offer no training and education are inherently cheaper, and those are the ones that are being commissioned more and more for short-term gain, for cash-strapped councils, but a long-term harm to public health. So I want to ask the Noble Lord the Minister whether he will address the three critical issues. One is making sure that all sexual health medical training posts are fully 100% funded through NHS England, in the same way that posts in primary care, oncology and health and public health care are funded. Secondly, the NHS England is accountable on its plan to ensure that improved recruitment with the publication of a corresponding action plan to deliver improved recruitment in sex and reproductive health. And third, that no service is allowed to operate without a GUM consultant within it, no matter how much it depends upon lesser qualified staff. My lords, it is worrying that we are going back to levels of sexually transmitted diseases, which we thought were a thing of the past. It is deeply frustrating because we now have the medicines to deal with these cases, and we know that there are new technologies and new ways of delivering services coming on stream that will could make the system so much more efficient. If we had nationwide home testing kits for HIV, if we had a greater use of pharmacies for the management of people with HIV in their local area rather than having to go to specialist clinics for ongoing treatment, we could be making great progress. And in this field, as in many others, other parts of medicine, were we can have with staff to have the time to sit and think through the ethics and the potential of the use of AI, we could make huge strides forward in these public health matters. As it is, these services are stretched to breaking point. So I want to ask the government for the Minister to answer two simple questions. What are they going to do to stop the crisis and the downward spiral of stretched services and with undertrained, relying on staff who are not sufficiently well trained? And secondly, what have the government made of the lessons that can be learned from the GP recruitment crisis and the opportunities to apply what's learned from that to increasing recruitment in genital urinary medicine and HIV, including fully funding training posts, because we need to get this workforce back up to the levels that we know we can manage in order to deal with a crisis which need not have occurred in the first place.
My Lord, I'd like to congratulate the noble Baroness on her contribution and really fully endorse what she has to say. We clearly have a crisis in sexual and reproductive health care. I would refer the Minister to evidence given to the Commons Women's and Equality Committee only in January by Dr Claire Dewsnip, President of the British Association of Sexual Health. And she said a lot of the presentations in clinics and potentially in other settings like primary and secondary care are things we've not seen for 50 or 60 years. And at the same session, Dame Rachel de Souza highlighted that in the past, school children could go to the school nurse with sexual health issues, but there's been a 35% cut in school nurses over the last 10 years. And this issue of access means that for young people, it's significantly harder to access sexual health services, particularly in rural areas. Now, currently, my understanding is only 10% of sexual health services offer a drop-in facility because of budget cuts, according to Dr Dewsnip. So that makes it far less likely that young people and children will seek the support they need. And my Lords, a further highly effective resource which has been totally cut is a Sexwise website. Now, this has been a highly valued sexually health resource for professionals and the general public. It was developed by the FPA in 2017 on behalf of Public Health England and was handed to PHE to run in 2019. But alarmingly, the Minister's Department ended the contract to deliver maintenance support for the website from 4th of March this year. And twice they've refused an offer by the FPA to take it over. And the reasons given are clearly spurious. The first rejection was based on Crown copyright considerations of the Sexwise brand, a ridiculous argument. And the second rejection, after the FPA clarified that the Crown can keep ownership of the brand, is quite frankly nonsensical. And the basic need for what Sexwise gave, which is accurate and free-to-access sexual and reproductive health information, has not gone away. And I do hope the Minister will instruct the DHSC to either put Sexwise out to a public tender. We're talking about literally tens of thousands of pounds cost. Or why not accept the generous offer of FPA to run it on their behalf? I'm afraid, my Lords, the Sexwise saga just reflects the government's attitude towards public health, perhaps apart from smoking. And I would just like the Minister to just reflect on the effective dismantling of the Office for Health Improvement and Disparities. This took over funding of the public health grant when Public Health England was disestablished in 2021. Which in turn, of course, replaced the Health Protection Agency following the 2012 Health and Care Act. Now, my Lords, we have unannounced changes to the office, which has been authoritatively reported in the Health Service Journal as having led to its fragmentation and decimation. So over 12 years, we've seen, through a number of iterations, the government essentially has moved from having a large, mainly independent public health agency to a disparate group of people spread thinly across a number of directorates in the Department of Health. And my Lords, at what cost I've seen reports that OHID has been reduced by about 60% in staffing terms, with a loss of several senior and experienced officials, and the downgrading of many functions, including sexual health. And can I ask the Minister to tell me how many qualified public health specialists have left OHID and how many remain within his department? And it's a far cry from the triumphal tone of the announcements launching the office, followed by the September 21 statement of the then Health Secretary, Sajid Javid, who said he wanted OHID to work on preventing poor mental and physical health, addressing health inequalities, and improving access to health services, and working with partners within and outside of government to respond to wider health determinants. Well, that, my lords, ended well, didn't it? So my noble friend Baroness Merrin anticipated this in her regret motion on 9th of November 2021. As she put it, it's hard to see how the UK Health Security Agency or the OHID could be independent or effective. They were not set up in statute and were created without parliamentary scrutiny or approval. And as we can see, it's very, very easy then to dismantle virtually the OHID without any public or parliamentary scrutiny whatsoever. And Hunter Littlejohns and Wheel, in a forthcoming BMJ opinion column, will be arguing that, set up in haste with no consultation, OHID lacks any of the independence that Public Health England had, being an opaque body scattered throughout the department. Given its low profile, lack of a clear mission, it comes as no surprise that despite denials from the government, it's been virtually eviscerated. Or as Dave West from the HSJ has put it, the latest restructure, as well as being damaging to a functioning national public health system, suggests any idea of greater push and support from the centre for ICS's long-term agenda of population health, prevention inequalities remains for the birds. Hopes of tougher preventative action on alcohol or sugar, for example, equally so. And, my lords, that has to be on a par with the government's tepid approach to public health measures, including smoking, aside. The shamefully postponed implementation of the obesity strategy is but one example. And it's in this context, of course, we see the problems arising in sexual health. How else can we explain the LGA analysis that between 2015 and 2024, the public health grant received by local authorities has been reduced in real terms by £880 million, which has been resulting in a reduction in councils' ability to spend on STI testing, contraception and treatment. And again, as David Hunter and his colleagues argue, revitalising public health in the UK requires changes, including a cross-government approach, to tackle the social determinants of health, alongside restoring the funding cuts to public health funding. And I ask the Minister whether he will effect that change, including restoring the real terms value of the public health grant, which has so decimated sexual health services in the way described by the Baroness Lady Barker.
My Lords, I very sincerely thank the noble Lady Baroness Barker for securing this debate. And I kind of slightly don't thank her that I've had to throw on half my speech out because she's covered it so comprehensively already, but it was a great introduction that really set out the issue of workforce that the subject directly addresses, but also the true crisis in sexual health. And I'd echo the reflections from the noble Lady Baroness Barker about the importance of relationships and sex education. That's the foundation of prevention. And that's clearly not being delivered at anything like the standard that it should be to our young people, and that means we are failing, utterly failing our young people. It's a pleasure to follow the noble Lord Hunt, and he and I have had our disagreements in recent times, but I entirely agree with everything the noble Lord just said. And I think very much I would echo his comments about public health, and that this government has essentially abandoned public health as a way of ensuring that we have a healthy society that enables the people in it to thrive and live to their full potential. And the failure to tackle the issue of ultra-processed foods, our broken food system, as well as issues around alcohol. I'd add the failure to restrict gambling advertising and indeed to allow the gambling industry to go totally out of control, which is meant our society presents a great threat to many people. But returning to the very specific issue we're talking about here, when I was reading the briefings here and I came across the term neonatal syphilis, and what I actually knew about neonatal syphilis before this actually came from reading history of Georgian and Victorian England. That's where my history came from, and if you read some of novels of that era, there's some very vivid descriptions. They mightn't have known the cause, but they could describe the effect. So I actually went and looked, and actually I came across a website for the Centre for Disease Control and Prevention in America, setting out the reality of neonatal syphilis, which is frequently stillbirth, miscarriage, or neonatal death. If the baby survives, among the effects are blindness, deafness, developmental delay, and skeletal abnormalities. Now, it's interesting that there's a real parallel between what's happening here in the UK with different structures and what's happening in the US, because the US, as the CDCP says, has an acute failure in terms of neonatal syphilis. The amount of babies being born with neonatal syphilis in 2020 was 10 times as much as in 2012. The CDCP says that testing and treatment during pregnancy could have stopped 88% of those cases. Now, the reason why I reflect on those US figures is because what we're seeing increasingly in our healthcare system is an Americanisation, a copy of the models of the US healthcare system, an import of the companies from the US, an import of people with professional experience, particularly managerial experience in the US system. And this is a system which the CDCP, citing the syphilis figures, says is a total failure. And I think that's something we should really be reflecting on. Now, before I come to the next section, I probably should declare my position as a Vice President of the Local Government Association. And I do have to pick up figures that have already been mentioned, but that have to be highlighted, that among the largest reductions in public health spend since 2015 has been on sexual health services, 29%. Yet at the same time, there's been a very significant increase in demand for sexual health services, nearly 4.5 million consultations in 2022, up a third in a decade. So we have, of course, we're always hearing elsewhere in your Lordship's House about rising costs, and sexual health clinics, sexual health services are no more immune from the costs of rising energy prices, rising staff costs, etc., than anywhere else. The funding's falling, the demand is increasing. So, of course, what's happening is the needs are not being met. And I think I have to reflect back on the debate earlier this week in the budget, and member after member of your Lordship's House got up and spoke about broken Britain and our broken services. And Noble Lady Baroness Barker for the government at the end said, "Oh, I think you're all being too gloomy." Well, I'm afraid if we look at the state of our sexual health services, the phrase broken Britain is really sadly appropriate. Now, I come and I acknowledge, drawing on the excellent briefings that we've received, to the particular issues around training. And we have received demands which seem perfectly fair and reasonable, that all sexual health medical training posts are 100% funded through the NHSE, in the same way as posts in primary care, oncology and public health are funded, and that the NHSE is accountable to ensure that some of those recruitment gaps, which the Noble Lord Hunt referred to, are actually filled in. And I think this is really important, and this relates to some of the other debates we've been having about the importance of expertise and proper full medical expertise being involved in all levels of the health service, that no service should be allowed to operate without a genitourinary consultant within it, and meetings of organisations and commissioners must include those. I come to a couple more very specific asks. Now, we have some contrast in asks from the briefings. The Terence Higgins Trust calls for a high-level sexual health commission to address these issues. The National AIDS Trust is calling for a national sexual health strategy. I don't have a particularly strong position which one of those approaches is the right way to approach this crisis, as all of these organisations are saying with different words. But is the government going to take a serious, significant step to act? Yes, it may not have very long to go as the government, but this is something that really cannot wait until we've had an election, whenever that is. I come back to an issue that I've also raised quite a number of times before in the House, which is about the patchy provision for postal STI and HIV testing across England. Only during one special week, the National HIV Testing Week, can everyone access this testing from a single service. That makes England an outlier. Both Wales and Scotland already have national HIV postal testing services. In Wales, that also includes STIs, and the Scottish Government is actually moving in that direction also. It would surely be cost-efficient and effective to have available to everyone a national, in England, HIV and STI testing service. It would be an extremely good spending of government money. I also briefly wanted to raise the issue of chlamydia testing. Now, we had the full national chlamydia screening program with both young men and women included, but that has actually been cut back in 2021 to preventing chlamydia infection to reducing the harms of untreated chlamydia. Now, the result of this is chlamydia has come to be seen as a women's issue. Of course, infection occurs in both sexes, but of course, the issue is not being drawn to the attention, particularly of young men. So will the government reverse that change and reinstate the full national chlamydia screening program service? And the final thing that I wanted to address was the issue about people living with HIV who are no longer engaged with services. Now, the government estimate is there's about 14,000 people who've not been seen at their HIV clinic for at least a year. That's a real risk to the health of people living with HIV and a significant threat to the government's goal of 2030 ending new HIV cases. Now, of course, disengagement is related to many issues relating to other policy areas, poverty, homelessness, many issues that the Noble Lord the Minister can't deal with. But surely there should be within health a program to re-engage people who should be being cared for with HIV in their own interests, but also in the interests of the national health and in the interests of the whole of society.
My Lords, I'm very grateful to my noble friend Baroness Barker for setting out the challenges so clearly in this area and some of the potential solutions. And we've just heard from Baroness Bennett really some real reinforcement about why this is so pressing and urgent as we see levels of sexually transmitted disease and types of sexually transmitted disease that go back to eras that I think we thought we'd move past. I first want to pick up also, though, on one of the comments that Lord Hunt made, which I thought was really important, this question of access and the fact that particularly for teenagers and younger people that the access to the school nurse in many cases has gone, but also the general crisis that we have around access to GPs, I think may have a particularly negative effect on this group. And I think we've all had this experience now. In order to get to your GP, that's really something for pushy parents. It's not something I think that reserved teenagers find easy at all. And so the generalised crisis in GP access, I think, may have a particularly negative effect on a group that we want to be able to go see the GP. So there's no school nurse. They're too shy to see the GP, and call it as it is, or find it too difficult. Where are they getting their information? And my first suggestion to the Noble Lord the Minister is I think it's really important that we understand that and that the government commissions some work. My instinct is they're probably going to TikTok and Instagram. And those may be useful sources of information. They're not the same as a nurse or a GP. And TikTok and Instagram, one of the things that they may do is provide initial information if it's done well, and then refer you on to a health professional. But we really need to understand that journey by talking to 14, 15, 16, 17-year-olds and understanding when they've got a concern, when they're doing the right thing, they're worried, where are they going, what's their experience, what kind of information are they getting, and are they getting to see the professionals that they need to see. And I think that in itself could really help. And again, I hope the Noble is going to say that that kind of work is underway. It's very, I know, difficult and sensitive, particularly when you're surveying teenagers about sexual issues. There's all sorts of legal and safeguarding questions, but I don't think that should hold us back, given the urgency of understanding what the experience of those teenagers is. In terms of the broader question around the workforce, there are three structural questions that I really wanted to put to the Minister and touch on. And the first is whether the Minister, hand on heart, can say that the government is taking sexual health seriously when we see the kind of cuts that we've heard about to public health budgets, and those are being compounded by crises in local government funding. So the people that we need to respond and provide that information, public health services and local government writ large, are bodies that are seeing significant cuts. And I hope that Noble Lord Minister can offer something. We've often brought funding crises to him, and there's been pots of money that have been found and dished out for various reasons. I've not heard of one in this space, and I hope the Noble Lord Minister will think about that. The fact that it's really hard to take the government seriously on this issue when the people that have to deliver this service are seeing their budgets cut year on year. Second question is one actually that, again, that Lord Hunt raised, which is around the role of integrated care boards, integrated care services. Now, I was interested to read the briefing from our friends in the library, which said in the workforce plan, it tells us that workforce planning, development and training for public health areas such as sexual and reproductive health and alcohol and drug treatment should benefit from improved joint working between ICBs and local authorities. I emphasise should. I don't think should is good enough. I would really like to hear from Noble the Minister any examples of where the government can point to and say they are benefiting from this ICB structure. I know it's early days. We've been talking about being early days, I think, now for about a year. At some point, we should be seeing the benefits that the ICBs should deliver. And I think this is one of those critical areas where it's that joined-up working and the pooling of resources between the two services, local authority-delivered services and sort of traditional acute and community and primary healthcare services that will deliver the benefit. And the third is on this workforce planning question, or the workforce planning questions, where I think the really interesting question is how all the different pieces are working together. Underneath the headline, which the government has talked about, and we, I think, on all sides of the House have praised the fact that we have these headlines, I think, again, it is time to dig into some of that detail. And there are really two key issues. One is to say, understand how these different pieces together, because there have been experiences, I think Lord Hunt's probably had experience of this, where a push to recruit in one bit of the health service leads to that bit of the health service that's now got the money and the attention, hiring people from some other part of the health service that then a year later finds itself in crisis. And I think we really need to understand for all of these services how those pieces are being meshed together. There's this sort of idea of, in a sense, it's a waterbed, and you push down on one point and another point pops up, and it needs that pressure to be applied very thoughtfully. It needs a bigger bed for a start, but once you've got that, you need to be really thoughtful about, if you're pushing down in one place and pushing up in another, how that works. And so I think it would be helpful to hear from Noble Minister more about how specific services like these, where you could imagine the recruitment for the service could come from another form of nursing or another form of public health, how all those pieces are going to knit together. And the second is to think about how people behave in their careers, and they behave quite rationally. And my noble friend Baroness Barker referred to the shortage of GUM specialists. As people are going through their training and building their careers, they're going to respond to signals about where the opportunities lie. And if they see that the funding is being cut in a particular area, they see that the jobs are not going to be there, they're going to make rational choices. And so again, I think we need to hear from local voters like what hope, and perhaps also from the opposition in an election year. We need to hear about what kind of signals the government can send out that means that somebody who's going through their early stages of their career, who is interested in delivering sexual and reproductive health services, how are we going to make sure that they feel it's worth doing the training because the jobs are going to be there at the end of it, because they are going to make a rational choice. And I think that's what we're seeing, and that's some of the suggestions my noble friend made are precisely around the fact that we are not getting the specialists coming through in this area that we need, because people are choosing to go and get trained in other specialties instead. So I think with those sort of key areas around the workforce planning, the Noble Lord the Minister will be able to respond to those and to the excellent suggestions that have been made by my noble friend. And again, I'd like to thank her for giving us this opportunity to talk about an area which is critical, I think, particularly for younger people, not exclusively, but particularly for younger people, and where mistakes are made at that stage where they don't get the help that they need, they can end up with conditions that are going to affect them for the rest of their lives, and we really need to do all we can to prevent that from happening.
My Lords, I'd like to start by congratulating the noble lady Baroness Barker on securing this important debate, and also for her very thorough assessment of what is a very worrying state of affairs, and that's something I'm sure the noble Lord the Minister has heard has been received with some unanimity of concern across the chamber. My Lords, the Health Foundation estimates that sexual health services will have seen spend lowered by some 39% between 2015-2016 and 2024-2025, which is far in excess of the already problematic 27% cuts to the public health grant. However, the situation gets even worse as the reductions in the public health grant tend to be largest in the more deprived areas. In Blackpool, for example, ranked as the most deprived upper tier local authority in England, the per person cut to the grant has been one of the largest. So perhaps the Minister could address how this disparity in the provision of funding for sexual health services, how will it be put right for people in the most disadvantaged areas? And it would be helpful also to hear how we've got to this situation. And my noble friend Lord Hunt raised some very key questions about the Office for Health Improvement and Disparities, which I would certainly want to echo. And I look forward to the Minister's reply on that, and also an explanation about how these cuts that are more extreme in the disadvantaged areas, how do they square with the government's levelling up agenda? I do anticipate, my Lords, that the Minister will tell your Lordship's House of a number of statistics to refute the negative impact of the reduced funding that I've referred to on sexual health services. However, a recent written question tabled in the other place by Rachel Maskell MP asked what recent assessment has been made of the quality and adequacy of the availability of sexual health services. Minister Leadsom replied, and I quote, that no formal assessment has been made of the quality and availability of sexual health services to meet demand nationally or locally. As this is the case, how can the government assure itself that it is satisfied with the impact of the funding that it provides? And how can it address, therefore, the very real questions that have been put in this debate this evening? My Lords, turning to the current state of demand, the Local Government Association, using data from the Office of Health Improvement and Disparities, reports on a number of areas. For example, that almost all council areas have seen an increase in the diagnosis rate of gonorrhea, with 10 local authorities seeing rates triple, whilst nearly 3/4 of areas have seen increases in cases of syphilis and more than a third of local authority areas have also seen increases in detections of chlamydia. It is interesting to note that councils, as well as other groups, have called on the government to publish a new 10-year sexual and reproductive health strategy to address infections in the long term. So perhaps the Minister could advise your Lordship's House what consideration the government has given to this proposal. An analysis by The Guardian just last month found that spending by English councils on sexual health services had reduced by a third since 2013, despite a rise in the necessity for consultations for sexually transmitted infections. Advice, prevention and promotion services have had the largest cuts to funding, with net spending down some 44% since councils were made responsible for public health in 2013. Meanwhile, STI testing and treatment fell by a third, and contraceptive spending fell by nearly a third. Yet we know that it is so costly for people to end up in hospital who could otherwise have been treated through sexual health and reproductive services. So could the Minister also comment on how cuts such as these make sense in terms of value for money when research shows that each additional year of good health achieved in the population by public health interventions costs £3,800, which is some 3 times lower than the cost resulting from NHS interventions that become necessary in the absence of this preventative measure. My Lords, the noble lady Baroness Barker was absolutely right to draw attention to the workforce that is necessary to provide services. There have been so many warnings that whilst a large number of skilled medical staff have left the NHS, that even in the unlikely event of a major injection of resources, it will just not be possible to replace that loss of the workforce overnight. I think that we are all agreed in this chamber that long-term workforce planning is essential to ensure the sustainability of crucial sexual health services. There is currently a retirement cliff edge for all members of multidisciplinary teams, and this has been exacerbated by difficulties in recruiting new staff into the speciality, as well as the experience of the pandemic, which saw more healthcare professionals leaving the sector. There is, as we've heard this evening, an urgent need to recruit new trainees by addressing the low number of training posts in GUM and HIV and low awareness of the speciality. In a survey of RCN members, it was reported that sexual and reproductive health is not regarded as attractive to new staff, whilst there were also concerns raised about the diminishing options for education and training. And this is borne out by the limited exposure to the speciality, which we see in undergraduate training and also as part of the core general training following medical school, something that the noble lady Baroness Barker highlighted. And in all of this, failure to plan and invest in the sexual and reproductive workforce only exacerbates the pressures that are elsewhere in the healthcare system. People are being pushed into hospital now due to untreated STIs, with admissions to hospital for syphilis and chlamydia doubling between 2013 to 14 and 2022-23, whilst gonorrhea admissions have tripled. So, as the noble Lord Allen referred to, the workforce plan talks about what I would describe as a hope that that there will be benefits from improved joint working between ICBs and local authorities on workforce planning, development and training for public health areas, including sexual and reproductive health services. In answer to a written question I tabled last month, the Minister confirmed that NHS England conducted an annual performance assessment of the ICBs for the 2022-23 financial year. So could the Minister indicate what assessment has been made of those promised improvements through joint working in respect of sexual and reproductive health services? In other words, is the joint working delivering in the way that the workforce plan hoped for? And importantly, how will the government address the very real issues that are highlighted in this debate? They are real, they have been with us for years, and they need resolution.
Yeah.
I would like to start off by adding my thanks to Baroness Barker for bringing this debate today, and also all the work that she does in this important area. I must admit, I was grateful for all the contributions. It did make me smile that when Lord Allen asked whether the solution to the sexual health debate should be one of a bigger bed. So I thought that was a very topical answer to it all, but I will come back to his bigger bed question in terms of long-term workforce plan a bit later on. But I have to admit to a bit of surprise when words used by Baroness Barker, such as crisis, and Baroness Bennett, such as broken Britain, were used in the debate. And really, to answer Baroness Merron's question about the quality and availability of services of sexual health, because thanks to our very own House of Lords Library, as I'm sure all noble lords saw in that, was a very interesting, very extensive research produced by the European Sexual and Reproductive Rights, performed just in October 23, and looked at 46 different European countries on a whole range of subjects in the area, for instance, of things such as access to abortion services. The UK came out third out of 46. On contraception, we came out first out of the 46th. On the HPV prevention, we came out third. On the gender-based violence in education, that we came out first. And you add those all up, and what was our overall ranking? First. And I must admit, I'm somewhat surprised because, again, we're a reasoned, balanced place, and this was part of the House of Lords Library. And I must admit, I was somewhat surprised that in the whole conversations that we've had in the whole debate tonight, and all the things mentioned, I was somewhat surprised in all of that. It wasn't mentioned anywhere that actually this body had done a very extensive research on it all and put us first, and commended us time and time again in that. I was also surprised when HIV was mentioned a couple of times, and on the UN target of what's called 95, 95, 95, in terms of 95% of cases wanting to be diagnosed, 95% wanted to be treated, and 95% wanted to make sure that 95% of people with HIV had an undetectable viral load. The UK, and I think we're alone in this, on diagnosis hit the 95% level, in treatment hit 98%, and undetectable viral load hit 98%. So actually, I think we might be alone, I will check, but definitely beating those UN targets. And the government action, which was applauded, noble members, lords will remember, recently by the visit by Elton John, in terms of standard things such as the opt-out HIV testing in every circumstance where people are going into A&E, which has already detected 1,000 people who were previously undetected in HIV. Absolutely groundbreaking in the world in all of that. And for the, again, applauded for the action of the HIV PrEP. So I must admit in all of this, call me old-fashioned if you like, but rather than looking about how much are we spending I'd rather look at the results we're achieving. And I would hope all noble lords would join me in all of that. And I think in terms of the results, I think undeniably by this independent source and by the HIV in terms of the UN target, we're actually coming out very, very highly indeed. Now, in all of that, I clearly don't want to appear complacent. Clearly, we have a situation where far fewer people are using condoms, often for very good reasons, because there's not the same fear in terms of sexual disease and HIV. So we know there are societal changes in that, but we know that that does bring some of the challenges that we see in terms of sexually transmitted diseases. So that is understood. But I think in all of this, what we are really trying to do and showing is that we're actually trying to make our funds go as far as possible in this. And that's not just in services today, but actually introducing the contraception and those services to the pharmacies and pharmacy first. It's making it very, very accessible. We're seeing already very good take-up in there, and we expect about 30% of people to be now getting their contraception through pharmacy first. So again, showing a real example of how we are massively expanding access to the workforce in all of this. And yes, the long-term workforce plan, it is a bigger bed strategy, absolutely. And I take Lord Allen's point that clearly we need to make sure that that bigger bed then is providing the individual specialisms that are needed. And I accept, as the government does, that work will need to be done to make sure those specialisms do result from it all. But I think noble lords will all agree that actually the strategy in terms of the bigger bed, so to speak, is the right strategy, and improvements will come through right the way across the board. I think in terms of Lord Hunt's specific references to sex-wise, I think first off, the moves we're trying to do, which are very sensible, we're all familiar in all sorts of life, and in fact the government did this very well in terms of when it consolidated a lot of its government different websites into single sources, is we want the primary source of information that we're pointing people towards is the NHS websites, and particularly the NHS app, which I think all noble lords would say is a completely appropriate way, particularly the NHS app, particularly appropriate for younger people. At the same time, I do absolutely take Lord Hunt's point about if a group are willing to take over sex-wise. I think that is a sensible thing. So, funnily enough, I mentioned exactly the point that Lord Hunt said is like, well, why can't we give them a contract for £1 if it's difficult about giving them away, or something pragmatic along those lines. So that's the challenge. I've set them on that. In that, if it's a good service and someone's willing to do it for that, then why wouldn't we want to support that? But generally, I would hope that noble lords would see that it is, it's a very sensible strategy in the digital age to really try and consolidate your assets around the overall NHS umbrella and NHS app. I think picking up some of the other specific questions, yes, we definitely do want to Baroness Barker's questions. We definitely do want to build on the women's hubs. We've actually got STI and HIV screening as part of those women's health hub specifications. And to Baroness Bennett's question around the pregnant women screening, we have hepatitis B, HIV and syphilis as standard parts of that as well. So, that is seen as very important, and absolutely agree with the importance of home testing in all of this. And actually, as noble lords will see, really trying to use the NHS app again as a real vehicle where people can use it to get home testing as they require on that. I think to Baroness Bennett's question about the chlamydia screening advice in terms of focusing that on women rather than men. That is absolutely based on the scientific advice and evidence that we've received, and that is the best use of resources in the case in point. I think in terms of Lord Allen's very reasonable question in terms of where young people are getting information from, I will write that what we need, what we know on that, and part of a detailed letter, and accept the point that if we haven't got that information, then that is a good thing that we should be finding out. But hopefully we'll come back on that. Likewise, I will need to come back more on in terms of what evidence we have to date in terms of the ICBs and the benefits from the joint working in all of that. So as ever on these, I will follow these up in terms of the detail on the writing, in writing. But I would like to say broadly on all of this, and again, as ever, I'm grateful for the opportunity for us to all debate these things. But it is, one of those occasions where I can really stand up here in all honesty and say, objectively, by a number of measures, as set out, you look at the results, not the funding, but actually the results that are coming, and by none other than the European Parliamentary Forum researching sexual and reproductive rights, Britain comes out number one, and I think that's something that we can all feel proud of.
My Lords, I beg to move that this House do now adjourn.
That the House do now adjourn.
The proceeding has ended. 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 The proceeding has ended.